because we've got some people substituting, some people who haven't been to our Health and Wellbeing Board before. You're very welcome, all of you. Thank you for coming. And before I do that, I'll just give some apologies. And for the avoidance of doubt, my name's Councillor Theresa Murray. I'm the Chair of the Health and Wellbeing Board, the Deputy Leader of Medway Council and the Portfolio Holder for Health and Adult Services. So today we've had apologies from Councillor Lawrence, Councillor Curry and Councillor Price, who are both on holiday, Paul Bentley from the ICB, and Martin Riley from MCH. Are there any other apologies, please? Jackie Brown from Medway Social Care. Okay, so Habib, I'm going to start with you. Would you like to introduce yourself?
Yes. Habib Tijan, a member of Medway Council, Shadow Cabinet Member for Business Support and Digital and Climate Change.
Good afternoon, Chair. I'm Kelly Cogger, Interim Assistant Director for Children's Social Care, Medway.
Hi, I'm James Harman. I'm Head of Children's Services Commissioning and Placements here at Medway Council.
Hi, I'm Councillor Peak for Wayfield and Weeswood.
Good afternoon, I'm Jane Perry and I'm the Pro-Vice Chancellor and Dean of the Faculty of Medicine, Health and Social Care at Canterbury Christ Church University.
Hi everyone, I'm Tass Alder. I'm the Projects and Engagement Officer over at Healthwatch Medway.
I'm Stephanie Davis, Committee Clerk.
David Whiting, Acting Director of Public Health, Medway Council.
Good afternoon, I'm Leanne Farrick. I'm the Director of People and the Deputy Chief Exec of Medway Council.
And I'm Councillor Tracy Coombs and I have the portfolio for education, including SEND.
Good afternoon, I'm Jane Black. I'm the Chief Exec for Medway Foundation Trust.
Good afternoon, everyone. I'm Suk Singh. I'm the Director of Primary and Community Care at the NHS Kent and Medway Integrated Care Board.
Good afternoon, I'm Dr. Patient. I'm a GP by background and also the Deputy CMO for Kent and Medway.
Hi everyone, I'm Dr. Jack Jacobs. I'm a GP and I am here today representing Kent Local Medical Committee.
Thank you very much, everybody. So I'll move on to the record of the meeting that we had on the 27th of June. Are there any matters arising before we approve them that won't otherwise be covered in the agenda? Under the agenda, we will have an update on women's health because this week we managed to have the meeting that we agreed last time regarding the menopause and sexual health provision. If there's nothing from anybody else then, we'll approve the record of the meeting. Is that agreed? Thank you. Are there any declarations of disclosable pecuniary interests or other significant interests, please? Okay, thank you. So I'm going to move on then to the next item, and that is the regulatory and impact of children being placed in Medway by other local authorities. Now, we've brought this item. Councillor Jones is just bringing up the rear. You're okay, Mark, we're only on item 1. You're just over there. Thank you. So this is Councillor Jones from Strood West Ward joining us today. We wanted to bring this item because there's considerable concern in the community and indeed amongst members and officers about the current way that we place people in our community who come from other authorities. We're not yet on top of a strong enough system so that we always know where people are and that we can work with the sending authority if things go wrong. And particularly lately, for James and for Kelly, we've had some troublesome encounters actually from Kent County Council placements, and Vince Maple and I spoke directly to Roger Goff, actually. We happened to see him yesterday, and we will have a meeting with members, I think, to make sure that everyone is across the issues. You know, it isn't that we don't welcome children. We understand that they need places, and absolutely we want them to have a regulated and safe place. But if we haven't got robust enough communication in place to understand where they're coming from, what their needs are, how their care is being organised but by the provider, that can bring us into, you know, our first encounter is often when something goes wrong. And that's not the right way to do things. I'm very aware as a politician this needs legislation, actually. But in the meantime, it's about working together to do the best we can for those children. So over to you, James and Kelly.
Thanks, Chair. I'll take the paper as read, but I'll just go through a few of the key points. So the paper, as you'll see, highlights a few areas that hopefully will be of interest to the board. I've highlighted a short section on the new supported accommodation regulations. They've been introduced by Ofsted. As you might know, Ofsted already regulate fostering provisions in children's homes. They haven't previously supported accommodation provisions for 16 plus. That now is in place. It's slightly different to how we regulate children's homes. Children's homes are done placement by placement, whereas supported accommodation will be done organisation by organisation, which is a good step forward, but it does mean that large supported accommodation providers effectively get judged at a corporate level rather than the 70-odd supported accommodation premises that might be under that. So it still leaves a role and responsibility for the local authority to make sure that each and every one of those accommodations is fit for purpose and in place. The inspection should start this month by Ofsted. We expect it'll take some time for them to get through it because, as you'll realise, there are a number of those supported accommodation premises across the country, so they're going to have to work through them because previously they haven't been regulated. So that's the first point. The second one, as Councillor Murray stated, is around the issues partaking to the volumes of young people being placed in Medway by other local authorities. These are children in care, and when we're talking about them, they are all under the age of 18. I've highlighted a number of data sets within the report that will give you some insight into those numbers. But as you can see, we've got at least 400 young people placed in Medway by other local authorities, predominantly London boroughs and Kent County Council. But there are other authorities within that. That is 3/4 of the amount of children that we've got in care ourselves, and over double the amount of children in care that we've got placed ourselves in Medway. So to put that in context, so there are more children in care from other local authorities living in Medway than we have our own children living in Medway. So that poses challenges for us to provide the support for those young people, but also provides some challenges, as Councillor Murray said, around the regulatory elements. If we don't have young people placed in these premises, in these accommodations, we have no right to visit, to oversee them, to ask them to move. So how do we manage the impact of that on our communities and on our services as a result of that number of young people coming in? We have got heat maps. It wasn't pertinent to bring them today just because it could potentially identify particular young people in particular places. But as you could probably imagine, that heat map is concentrated on a 3 square mile radius in the centre of Medway, pretty much sort of between Gunwharf and the hospital, if we're putting it in that sense. It's that area there. You do have odd ones out in other areas of Medway, but we're talking a majority of those 400 young people are in a 2.5, 3 square mile radius in the middle in some of our most deprived areas. With that, all of those young people are obviously entitled to all of the statutory services that come within Medway, so accessing GPs, dentists, school places, social care, all of those sorts of things. So it does have that knock-on impact on our services. So the reason why we felt this paper was pertinent was just to give partners a wider understanding of what was going on, but also to see how we can better work together to meet some of those challenges, to support some of those young people in a better way, but also work with those other local authorities to make them aware that some of these placements are not safe. You know, they are with providers that we ourselves would not deem as appropriate for our young people, or indeed in streets where we know from some of the evidence from our police colleagues have got other challenges within those streets that might be linked to kind of criminality, it might be linked to vulnerable adults, you know, all of those sorts of things. So I'll probably leave it there as an overview and then take any questions people have.
Thank you, James. But before we take questions, look, from a political point of view, we're considering bringing together representatives from these authorities and trying to get a protocol that at least is based on sharing information and, you know, sort of putting our cards on the table and saying this is having an impact on our community. I mean, I'm interested to hear what services think, but, you know, what is blatantly obvious and actually not very laudable is that the placements that are being provided, as James has said, not only are they unsuitable, but they are in the cheapest property in the most deprived areas. And I'm afraid that is a sort of derogation of responsibility towards those young people. The other authorities have got their difficulties, but they should be doing better than that for their young people. And our community, you know, I want our community to be sympathetic. I want them to understand that we want to protect everybody. But as I'm sure you can all understand from James's introduction, this is not a good place to start. So, as ever with the Health and Wellbeing Board, collective heads together, you know, I've spoken about the protocol at political level. Are there things that we can do? And I'm extremely mindful that this is putting pressure on the hospital and indeed on our already incredibly challenged GP services, if only in terms of numbers. Okay. Tracy, first, please.
Thank you very much, and thanks for that report, James. It made really interesting reading. I think things are really difficult for us as a local authority because of the lack of regulation. Many of these providers, they're basically businesses that have been set up, and when we're not using them, they're looking for others to use them, which is why we're getting other local authorities sending their young people into Medway. And we've mentioned Kent County Council, and I know that they've got a number of people there. However, we are in touch with Kent County Council, and they're in agreement with us that these providers are not providing suitable accommodation, that the young people are not being properly supervised and looked after, and they remove their young people. These businesses will go and look for another local authority to place their children there. So this will not solve the problem. We will be constantly having to communicate with various local authorities as these places get filled up. So as you quite rightly say, Teresa, this needs legislation, this needs proper regulation. The Ofsted is a first step, but I'm not sure how much of a difference this will make, quite honestly. There's a huge backlog already because of the new registration. The inspections, as you say, are for the overall, it's not the premises, it's the overall organisations. So, you know, residents who have concerns are not necessarily going to be able to report the concerns of the individual placements that they are talking about. So I really think that this goes much deeper than we as a local authority can have much influence over. I'd mention as well that we had a meeting a few months ago where in a particular area we've got 3 providers in a small street. The providers did all come together, as did the placing local authorities. Each of the providers said, had we known there were going to be 3 of us in a small street, we wouldn't have bought the houses. But there's no communication, they don't have to go to planning, there's no way of them telling what's already there. So this needs really, I think, lobbying at a higher level to bring in stronger regulation and stronger support for local authorities. Meanwhile, we still have to do what we can for these young people and for our residents, and to help to support these providers to become better providers effectively, to give them better supervision, to better training for their staff and so on. So I think that's where we can come at it, but we're very much tied. And I think as well, it's really difficult for our children's services when it's not our children in there, because you're working very hard for Medway children, and you're also having to work for effectively other local authorities to try and support them. So it's increasing your workload as well, and I do appreciate that. So thank you for the report.
Thank you, Tracy. I'll take Eddie, then Habib.
Thank you, Chair. For having a long-term...
Turn your mic off, James, please. Thank you.
A long-term strategy for a complex and long-term problem. I'm not actually aware of how much difference being part of the National Transfer Scheme is, so we'd like to maybe get an explanation of that. I've got two questions. On page 17 of the report, whilst I expected, well, I should say not surprised, that the 16 to 18 age group would be significantly higher for 2 years in the number in comparison to other ages, can you give us a reason why that's particularly high in that age group? And the other question I've got is, what is our understanding of other issues relating to these children? I'm speaking with my ex-Porch Light hat on, when for most of the people I supported, they were average age of 17, homeless children, also now work in mental health. A lot of the disruptive behaviour of these teenagers, when you looked at their backgrounds, there was very, very stark and alarming issues. You then get to realise why they have such difficulty settling down, staying in place and having relationships. So an understanding, I mean, if it's not the right place for this remit, then so be it. But we, overall, would be much more helpful, much more productive if we could have a really good understanding what else is going on. And that includes what's been mentioned is about where they are placed. Porch Light actually had a criteria that when we took somebody on, it definitely could not be near to family and friends. It's opposite to what you may expect, because quite often it is the family that's been abusive, and it is the friends where you've got gun, gang, and drug-related issues going on. Thank you.
Thank you, Eddie. James, I'll go to Habib and then come back to you.
Thank you, Chair. Yes, no, thanks for the report. I mean, this is a complex problem, as you alluded to earlier. It is not unique to Medway. So it made me just ponder, thinking, what is going on elsewhere, whether there's any learning from any other authorities facing these same problems. What are they doing differently? What can we learn from them? And whether there's been any case studies as to, a great success story with regards to placement of people in different authority, and whether any of these strategies has been implemented, that you can say, yes, that was successful. Now, I also would like to understand whether there's any arrangements in place between authorities to ensure that out-of-borough placement notified, monitored, whether there's some sort of communication going between authorities for us to be able to best prepared and make the necessary resources available. Thank you.
Okay, James, if you want to come back before anyone else comes in.
Yeah, I'll try and answer those in order. So National Transfer Scheme, which is the unaccompanied asylum-seeking children. Since Medway joined the scheme last year, we've accepted, I think, 38 young people. 35 of them are still placed by us. Our allocation through that scheme is 63. So that's the target, which means we have our quota of young people. So we are working really closely with the National Transfer Scheme, and we've taken quite a few young people over this summer as a result of obviously the boats increasing and those sorts of things. All of the over 16s within our NTS transfer scheme have been placed either within Medway or the 20 miles a radius that we're given, so that's your sort of Sittingbourne, Maidstone, Gravesend loop, which is the regulatory, what we should try and do and place our young people. There are a few young people that have gone out to other areas in foster placements, but that's due to that market, so we have tried to keep them as close to our own services as possible. I think the second part of that was around the higher age bracket. Part of that is around the lack of regulation in supported accommodation, that if they're under 16, children's homes, fostering agencies are regulated. It's a much more, the market is much more stable in that sense. There are pretty much set prices. A children's home is pretty much a set price. A foster agency is pretty much a set price. With supported accommodation, without any regulation behind it, somebody could charge £500 a week, somebody could charge £1,500. Doesn't matter on the quality, and because nobody's overseeing it, people can draw their costs down and cut corners where maybe you can't if you've got a regulatory body behind it. You've also got the increased risk that older young people have around, gangs and, criminality and family issues and all of those sorts of things. So that's why it's a higher age bracket that are coming into Medway. And that's where we're getting a lot of these providers that we're not aware of that children are being placed into. The second bit is, I think, was there anything to do about influencing where they're placed? We have no statutory rights to stop that. We can inform local authorities that we feel that's not an appropriate area, or that there are risks linked there, or there is a lack of services, school places. They don't have to listen is the sort of tall and short of that. Has there been any learning from other local authorities? I mean, the most local one a few years ago was Thanet in Kent, which had similar challenges around lots of local authorities placing in Thanet. That came under the Margate Task Force sort of model of quite a few years ago now. The other one that's had similar problems but probably has a more notable approach to that is Blackpool. And there have been, because so many people placed in Blackpool over the last few years, they've now, and I can't quote you on it, but there are some regulatory things that have been put in place in Blackpool to prevent other local authorities placing more young people there. So that might be a blueprint that we could look at to see if there are any similarities within that. Anything else we could do? We could potentially share our embargo list of providers. That's based on our judgment and our framework rather than anybody else's, but that could be a way forward that we say we don't feel these providers are fit for purpose. And notification process, which I think is the last bit, and we actually had a discussion this morning at Kelly's management team about that. There is a formal process where we will notify other local authorities if we're placing a child in their authority and vice versa. Does it always happen? No, but a majority of them do. So we are informed that they are going to be placed. What we don't often know is the quality, or indeed that provider, when it comes across to us that says this young person is being placed within our remit. So I think that covered all the questions. Yeah.
Thank you. Yes, Habib, and then Kelly.
Thank you, Chair. The last bit was just the monitoring side and probably reporting back whether whether we are monitoring children being placed here and children being placed elsewhere.
I mean, we monitor it in the sense of these numbers, so we're always aware of these numbers. We'll look at this on a regular basis. We'll run the reports. We won't necessarily monitor we'll monitor our children elsewhere. We'll do the social work visits. We'll do our quality assurance visits, and we're regularly in contact with those providers. And I'm confident that we do a really good job around ensuring that providers are of a good quality. If not, we'll move our young people, whether they're in area or out of area. I can't say that everybody else does the same or has got those same systems in place. So we certainly will do that, but with the children placed here, we don't have any statutory responsibilities to monitor those children or those particular services, but obviously it then does cross over into the wider council remit, which is kind of around safety and community cohesion and all of those sorts of things. So it's a really complex, situation about where our roles start and stop.
Just before you come in, Kelly, look, Habib, just to reiterate, we are not using these providers ourselves, and we haven't got any control over them. These are providers who are being picked up by other local authorities. So the onus is on us, I think, to sort of set a gold standard and to work with the providers, and I've got a proposal related to that. The other thing I think it's important to reiterate there is that actually the unaccompanied minors are not the ones that we're worried about. They are part of our allocation, they are part of our children's services. We know where they are and we know what they're doing. And for your interest, I was very pleased that we had actually some of them at the Looked After Children's barbecue. And it was nice to talk to them and see that they are happy and settled in Medway and doing that unifying thing of playing football together from many parts of the world. So that is a different group of people. Okay. Kelly. I beg your pardon?
My point's passed now, so that's fine.
Okay, yeah. Thank you. Can I just ask Sook, Ash and Jack, and indeed you, Jane, are you aware of the way that this impacts on medical services? Do these providers with children in this situation make a special effort to approach you? Do you think that they get them registered quickly with GPs? Have you got anything that any insights that you can offer us that might be helpful to the way that we manage them?
I can give you anecdotes because I come from Thanet, and in fact I work in Margate where the Margate Task Force is. So I have a first-hand experience of looked after children being placed in our areas with not much information to the local council or to the GP surgeries, and we just pick them up as a routine, while they're coming and visiting us, and then we find out that actually this is the cohort of looked after children. And slowly what's happened is most of the practices in our area have built a list of, we specifically put alerts that these are looked after children. And sometimes, very few sometimes, there's not a lot of sometimes, we get information from the councils which are placing their children that they have been good enough to let the local GP surgeries know that these are looked after children being placed. So that does create a lot of challenge for us because we are getting far more kids coming into our area than we normally be expecting. And that does put a little bit of pressure on the primary care in that area, especially in a more deprived area like Margate, because we have got our own challenges on top of that. But thankfully, we have something like a Margate Task Force which helps us manage this far better.
Okay, thank you. Right. Well, what I'm going to propose is that in addition to the political work we're doing, that we write from the Health and Wellbeing Board, at least to the authorities that we know, to say that this has been a focus for us, to ask them if they are prepared to engage more readily and over a greater range of criteria and aspects than they are already doing for all of the reasons that we have said, and make that a starting point. And as I say, the political protocol is something that we are working on. But I think, yes, I'll come to you, Mark. I think collectively, they are here. I've got to look after them as best we can, and I don't want us to have a message that somehow we're trying to, offload the responsibility that we've got, people living in our area. We've got to be careful and to work with everybody, and that includes the wider community. It may be that we perhaps can do a little bit more with our youth services, and that there are things to explore. It might even be, and I'll perhaps talk to officers more about this, that we have a bit of a task and finish group to think about how it goes across the council. But I think from the Health and Wellbeing Board, that letter needs to go. Mark.
Chair, I was simply going to second all that and to say I find it quite surprising actually that other local authorities are not obliged to listen to our comments on things like pressures on the local schools and GP services.
Yeah, I think, Mark, this is why we need regulation. So there's some government lobbying that needs happening as well through the LGA, I think. Leanne.
Thanks, Chair. I absolutely agree. We need to do something, but we also need to understand that there could be another Health and Wellbeing Board at another local authority meeting right now, considering that Medway has placed children in their area. So we need to be very balanced about our view, but so long as we're coming from, a safeguarding perspective, which we absolutely are, and the best intentions for the health and well-being of our young people, I don't think we can go too far wrong.
Thank you. Okay, that's the end of that item then, with that action very clearly there, and I think this is something that we'll come back to, and that in the wider council, as I say, we've got some more work to do. But thanks everyone for your contributions. Yes, I'm just going to. Thank you, Steph. So just going to Jane to do what the recommendations are asking us to do with the additional action, please.
Okay, so the board is asked to note the report and include the impact and the challenges that were highlighted. It also notes the changes in the regulation to the supported accommodation coming into effect of October 24, and also picking up the Health and Wellbeing Board will write to other local authorities to ask to engage more, but also begin to work on or continue to work on the political protocol and may propose a task and finish group to look at those things.
Thank you, Jane. Is that agreed, everyone? Okay, thank you. So we're going to move on to agenda item 6, pharmacy and dental services. And just to remind people that the items are being generated out of our local health and wellbeing strategy, which we want to keep very live. And as the paper informs us, coming through the primary care strategy for 2024 and the sustainable local care 5-year plan for these particular services. So it's over to you, Suk.
Thank you. So just introduce myself again. So I'm Suk Singh, I'm Director of Primary and Community Care at the ICB, and I've got Ash here with me as well to support with some of the questions. So as colleagues may know, we've been to the scrutiny committee this year where we spoke about dentistry and pharmacy, but I thought the opportunity today with the Health and Wellbeing Board is maybe just to set a bit of context in terms of the national direction with pharmacy and dentistry, then what we're doing locally, as Councillor Murray mentioned about our strategy. And then at the end, I've kind of wanted to go into some of the challenges, but also the opportunities that are there. And I think some of this is around how we collectively work around some of this, and because particularly around the partnership working with public health. So I just kind of wanted to preface that in terms of what we're presenting. If I skip to the first slide. So what we really wanted to set the picture of is that we have now delegated responsibility for all of primary care, so the 4 pillars of primary care, as we call them. So historically, we've been responsible for general practice, but now we have responsibility for pharmacy, optometry, and dentistry as well. When I present this to other colleagues, I think one of the things I just wanted to make people aware of is that when you look at the amount of providers that are providing primary care services across Kent and Medway, there are over 1,000 providers that are providing NHS primary care services. And I think the opportunity there is the fact that these are really well located in local communities. And actually, maybe that's part of the opportunity of what we can explore is about how do we kind of get that outreach, that engagement through our primary care providers. But the key thing that we need to do is obviously just try and make them sustainable. And I think there are some big challenges that we've got with some of our providers, as we've seen, and I'll touch on in some of the slides as we talk through them. And it's just at the bottom, we just wanted to make sure it's clear about our responsibilities as an ICB. So we're responsible for commissioning and contracting those services, but also providing that leadership and transformational support to them as well, so that they can continually evolve and develop to meet the needs of our patient population. When we started to work through our strategy, what we initially identified is that we've got a vast area of Kent and Medway that we're trying to address some of the challenges around. But actually, if we really wanted to take a targeted, focused piece of work around how we start to address those needs, we wanted to say, actually, let's look at, I guess, our most challenged areas. So this can be a combination of there's growth in terms of developments and housing and population growth. There could be around deprivation, workforce challenges, and then patient access challenges that we hear. So what we've done is identify those 6 areas, and Medway is one of those 6 areas that we've identified that we need to provide additional capacity and support into. Just to, I guess, set the direction in terms of what we're doing with community pharmacy. So historically, community pharmacy have been there for dispensing medicines to patients, and that's quite often what patients have used them for. But what we have now is community pharmacies that are offering clinical services to patients. And what we need to do, obviously, is take that opportunity and that advantage of actually trying to make sure that they're open and available to patients in a consistent manner. But also the other bit that we really want to try and tackle is how we can build confidence and trust for the public in terms of accessing those services, so they know what I can go to my community pharmacy for versus what I would then maybe go to my GP for or other services for. One of the things that we're looking at, and this is, I guess now because we've got delegated responsibility for community pharmacy, is it's great, we want to put more clinical services into community pharmacy and we want to promote that to the public, but there isn't a array of pharmacy workforce out there that are there to be able to take that resource and that pressure. So in terms of our training and education offer, it's one of the areas that we want to have a look at for community pharmacy. So we offer a lot in general practice, but I think as we're seeing, we don't have that parity of offer for pharmacy, optometry and dentistry as well. So we've just started that conversation. But the other thing is around how they can work really closely with general practice as well. And we've just put a case study in here about some really close working between a practice and a community pharmacy that has yielded benefits for both patients and the providers. So we've managed to free up GP time. We've also managed to make sure more patients have been seen as a result of that service. This slide just illustrates us as some of the national services that we've got that are now in community pharmacy. So we've got the pharmacy contraception service, we've got the hypertension case finding service, we've got the pharmacy first service that is available within community pharmacy. The thing I just wanted to make people aware of, though, is it isn't mandated that every pharmacy in Kent and Medway or nationally have to offer those services. Pharmacies can choose to sign up to those services, and sometimes for very good reasons they may not sign up to these services, because it's about making sure that you've got the appropriate workforce, you've got the clinical skills in place, you've got the facilities to be able to offer that, and it's also being able to then actually make sure that you can manage that additional workload that then comes through as a result of offering those services. When we look at dentistry, when we compare our Kent and Medway position in terms of the number of dentists per 100,000 population, we've got a better than national average picture of dentists. But I think if you were to ask most people if they feel like it's easy to access dentists, they'll say no. So we know that it still isn't enough. There still isn't enough dentistry access out there for our patients. What we're trying to do, so there is, and I'll touch on it in a moment, about the national programme, about the recovery plan for dentistry, and also some of the contract reforms that are happening as well. But actually, we want to maybe to do something locally that actually tries to make a difference in this. So the main thing that we're focused on is how we really target our commissioning activities for dentistry activity and put more capacity into our most deprived areas. So what we're trying to look at is that rather than saying there's a blanket 1.2 units of dentistry activity per head of population, is that we want to say in our most deprived areas we want to have 1.5, so more capacity in those areas. And in the more affluent areas it might be 1 unit of dentistry activity per head of population. And I think in the bottom right of the screen, what you will see is that through that proposed approach, Medway would be the biggest beneficiary of that, because actually what we would want to do is get them from the position of where they've got 1.4 units per head of population to 1.5 units, which would then result in an additional over 100,000 units of dentistry activity being put into Medway, and on an annual basis. So we really want to make sure that we take that targeted approach to improving dentistry capacity. One of the challenges that we do have, though, is that unlike GPs, there isn't a catchment area for dentists. So anyone can go anywhere to access an NHS dentist. And we've had an example of someone who's travelled from Norwich to Medway to access their dentistry services. And actually that just shows some of the challenges that we do have as part of this. But I think actually just putting that capacity into those areas, it means that we can really make sure that those people that should be eligible for NHS dentistry, so children, pregnant women, exempt groups, we really want to make sure that we have that capacity there so it's really easy and accessible for them to be able to access it, or better than what it is now. This slide, we just wanted, I guess, set the direction in terms of just explaining, I guess, the service available in community pharmacy, but also when they went live, the number of Medway pharmacies that have signed up to deliver those services, and then also the number of consultations that have been delivered last year, or where there are new services, those that have been delivered in the first couple of months of this year. So you can just see the volume of consultations and patients that are going through these services. But as I said, there's more we can do to kind of raise awareness and people just being aware that these services exist and are there to support patients. So just, I guess, touching on some of the challenges and opportunities that we have. So I think people will know one of the challenges that we have with community pharmacies is that we have had pharmacy closures, particularly through some of the bigger chains where they've been taken out of supermarkets or some of the other areas. So we, I guess, just need to understand, I guess, what the impact of those are. And I think that actually the opportunity, and I know that there's an opportunity to revise the pharmaceutical needs assessment, but I guess that's part of what we need to build into that. Actually, what's the impact of pharmacy closures, where we maybe have gaps across Medway, and how we make sure that we mitigate against that. The other thing, and actually these 2 points kind of link together, it's the bit I mentioned before, public awareness. Public awareness of pharmacy first, public awareness about hypertension case finding, public awareness about contraception services that are available within community pharmacy. So I think there's more we can do about joining up our communications, particularly working really closely again with public health colleagues about making sure that we really promote those to our patients and our population. In terms of the contraception service, the only other thing I wanted to kind of mention here is, I guess, it's also an opportunity to join up our services. So there's stuff that we get commissioned through our health service, there's stuff that Public Health Commission. I think it's actually making sure that that one offer is available to patients so they know what services are available to them. And we make it easier, I guess, but also, I guess, the other thing you mentioned there was around training and for staff as well, and making sure that we've got an approach to make sure that we've got skilled workforce that can deliver those services to the patient population. For dentistry, so as I mentioned, there's a national dental recovery plan. And there are some things that they targeted in there. So they've set firstly that there's a minimum rate per unit of dentistry activity gets paid to providers. So across Medway now, that's been enacted, so every provider gets that minimum rate for their NHS capacity. The other things that they've got is a new patient premium. So these are people that haven't been seen by an NHS dentist for 2 years, and how it just encourages more of those people to come forward and get their NHS provision. And one of the things, and I'll show it on one of the other slides, what we are seeing is that new patients are increasing when you compare the activity volume levels from what it was like this time last year to what it is now. So we're hoping that that is as a result of that incentive being put in. We've also had there's some workforce reforms that have been suggested, so some of that we're going to have to see how it plays through. But we've also got the Golden Hello for dentists, similar to what we did with the GP attraction package. So we offered that out to dentists across Kent and Medway in Medway, Thanet, Swell and Dover. And that was for 10 places. We had more people apply than we had spaces. So at the moment we've approved 3 of the 10 in Medway. So there will be 3 dentists in Medway that will take part in that programme, but we're hoping to put it back out again to try and encourage maybe another 10 that might be able to come through that programme. So again, I think the positive thing here though is that we had interest, and I think actually that's a real big boost in terms of what we can offer in terms of NHS dentistry provision. The other thing is on the right, mobile dental vans are on there, but Kent and Medway hasn't been identified as an area in need of mobile dental vans from the national scheme. And then just in terms of the right bit, we just mentioned about the public health initiatives as well that have been included as part of the recovery plan. So that's set nationally, but again, it's that partnership working with public health around making sure that we align the work that we're doing. This slide here is what I mentioned before. So when we look at, I guess, adults and children seen by an NHS dentist, so these are new patients within 2 years, when we compare the bottom line, which is last year's data, and then the top line, which is this year's data so far, there has been a notable increase in the number of new patients being seen, and particularly for children, that's risen quite significantly more than what we had in terms of our targets. So I think it's a positive step forward. We know that there's more to do, but actually just making sure that we can provide that access is really important. So some of the challenges, similar I guess before, is around I guess dental closures, and I think it's actually there's work that we're doing. So we're meeting with the local dental committee just to understand what those challenges might be and some of the things that we might be able to put in place to help improve that. But I think there's a big challenge about people wanting to take on NHS dental contracts versus maybe what they can get from private. But we need to make sure that we can maybe offer, what is it that we can offer in the NHS? What is it that we can offer in terms of, again, it's training and education. We have a good kind of background of support that we can offer. So I think it's just trying to make that offer available. And actually that's, I think, the hook with the Golden Hellos. It's that thing that we're offering for the NHS that they wouldn't necessarily get through other areas. Understanding our dental demand better. So I think there's an opportunity with the JSNA in terms of how we can bring that together, what we can do around oral health surveys. So again, really working closely together to make sure that we are targeting what we're doing from the NHS perspective, which aligns to that population health need. Patient engagement, so I guess I mentioned first and foremost is that there's no catchment area for dentists. So some of those things people just need to understand. Dentists you're not registered with a dentist like you are with a GP, so don't stay on their lists until you've kind of find another dentist. So things like that are really important for people to understand. But we do have a website where you can find a dentist and you can see what they're offering, and dentists are required to update that every quarter. So again, making sure that's available for patients so they can then start to look around or which dentists are most closely to them that are accepting NHS patients is available as well. And the workforce slide I mentioned. So we have a challenge around trying to attract dentists to work in NHS contracts, but I think actually the Golden Hello has demonstrated there is something that we can offer in the NHS to our dentists. I'll stop there. I've just whizzed through. I know you've got the papers as well, so hopefully most people have read that, but I just wanted to put some context around that. And then between Ash and I, we're happy to take any questions or comments.
Thank you very much, both for the presentation you've given today and for the papers that came to the board, which I hope and believe that everybody will have read, because these are critical issues. I've got a couple of things to say myself, and then I'll open it up more widely. On pharmacy, and it's helpful to have the case study for the maritime practice, which we tend to use quite often. One of the reasons we use them quite often is because, and actually Jack and I were talking about this last night, they have up-spec'd their tech very, very quickly and very determinedly over a long period of time, haven't they? So that puts them in a strong position both to respond to their patients and to respond to pharmacies. And I'm aware that pharmacies have to fund their own ICT. So that alone, I think, is a barrier to pharmacies joining the Pharmacy First programme, because without ICT that is compatible and will link with the other people that they need to link with, it puts pharmacies in a very, very weak position, and it sends patients going round the loop. Now, when we had the initial GP task groups, we looked at this, didn't we? We looked at it with pharmacies. I don't think anything has particularly changed, but I think that is there to be faced. If a practice has not got the sort of technology that the Maritime have put in, together with a very big training programme there that I have seen, and am as convinced as I can be as a layperson by talking directly to the staff and to the patients, works very well. But it didn't happen overnight. It was a long process that has included on-site technology specialists, on-site trainers who stayed with the teams for a long time until they got to grips with it. And for those of you who haven't seen this sort of stuff in action, you know, it is very skilled work. These are people processing 4,000-6,000 calls a day, looking at 3 screens to do so. It's not something that, you know, we could, if you think you know about computers, you could just sit down and do. It actually is a very nuanced and complex set of processes. So I think ICT is a barrier to people joining. I'm worried about pharmacy cover in Borstal. The pharmacy there is closing. I think it's important to there's only one. It's an area that is quite poorly served. I continue to be worried about pharmacy services on the peninsula. There are no late night services there still. A growing population, the potential for more growth as we go into a period where we're consulting on the local plan. And apart from the fact that our own population here now are growing by dint of people living longer, we've got people moving in. So I think they are 2 areas that I do, you know, hope that the ICB can be very aware of and concentrate on. I've raised the point about ICT. It may be that Jane Perry, you've got something to give us in terms of training for pharmacists. It would be interesting to hear that. On dentistry, and I've looked at these statistics for quite a while, and on the face of it, you could say, yeah, you're doing very well in Medway compared to other people. That does not seem to be the case when you meet people and look at their oral health, which in particular areas is very, very poor, and strikingly so. We've done a huge amount in public health to raise awareness. But I think, you know, there's a collective issue for all elements of the NHS. You know, I would like to hope and believe that when a GP sees somebody whose oral health is shocking, that there is the space not just to deal with whatever problem that they've come along with, but to say, look, you need to see a dentist. You know, I think when people's teeth fail, it puts them in an inherently weak position, doesn't it? You know, access to healthier food becomes more difficult because it's actually more difficult to eat than just eating, you know, soft processed stuff all the time. So they get behind the curve very, very quickly. And as we know, you know, there are many other problems associated with that. And I honestly think we need a push on this. It's been deprioritised with the cost of living crisis as well. So people, you know, put going to the dentist down their list. I'm pleased to hear there are a lot of new appointments. And as part of the engagement, absolutely, I think we've got to focus on making sure that people understand who still get free dental treatment, particularly children. I think because of the kind of rise in the offer of private appointments, people forget about the rights of people who get it free. And there's this great dissonance, isn't there, between cosmetic dentistry, people getting gemstones put in their teeth and having, you know, teeth that need a filling before they get whitened. You know, there's all of this sort of modern challenge for us to face. But it's really good to see this focus. So I realise I've asked a couple of questions. They can probably wait until other people have been there, but that general, you know, use of technology to get pharmacy first going and how pharmacies are supported to join that. £14 per consultation doesn't seem all that much if you haven't got premises capable of giving people privacy and space, and you haven't got technology to connect you up with everybody you need to be connected with, then it isn't at the moment, I think, for some pharmacies a very attractive offer. And on dentistry, that sort of joined up thinking with everybody involved. Okay, I'll open the floor now. So Tas first, then Leanne, then Habib, yeah, then Jane. Thank you.
Thank you, Chair. I sort of have a two-part question. Around the pharmacy closures and the dentistry closures, you said that you wanted to better understand the impact. Is that the impact just on patients, or is that on the system as a whole, or is that sort of all of everything? And my other part of the question was, you speak about public engagement around both pharmacy closures and dentistry closures and the impact of that. And I was just wondering, I'd be interested to hear your strategy for that. Thank you.
I think it's better to answer each question separately because they're coming from quite different sources now. Thank you.
So I think when I was talking about the impact, I think it's all of it. So I think first and foremost it's patients. We need to actually understand what's the impact in patients being able to access services, and then kind of where we've had maybe some closures, what's then the geographical distance to the next available pharmacy, for example, and actually what does that mean for patients in terms of access and links. And as I said before, that's where we need to join up with what happens, because public health will do your pharmaceutical needs assessments. The pharmaceutical needs assessment last time, because these clinical services weren't available, didn't include that. So actually the other aspects we do need to have a look at is if we've got some pharmacies that haven't signed up for hypertension or contraceptive services. And I think your point, Councillor Murray, about I guess where there might be provision gaps in Borstal or in the Peninsula, I think we need to pick up that as part of that needs assessment. And then actually, because what the danger we've got is that we'll be doing something, but then doesn't align with what I guess then you're picking up from the public health perspective. And I think that's what I'm saying is that we need to align that together. And that's why I then want to know actually what do we need to commission to bridge that gap that might exist in terms of what then public health have found out from their needs assessment. So I think that's what I would be looking to do. So understand the impact for patients first and foremost. We can then build that wider system impact, see what the pharmaceutical needs assessment says, or other needs assessment, or the JSNA if it's around other areas, and how can we as healthcare commissioners then look to bridge that gap.
Thank you. Leanne.
Thanks, Chair. I was really interested in the mobile dental vans and the bit in the slide that said Kent and Medway hadn't been chosen, and that got me to thinking, because if we are overly reliant on the NHS recovery plans, then that particular bureaucracy can grind things to a halt. And so computer says no, so everyone says no. But I wondered, you know, there are charities like Dente, Dental Wellness Trust, all of those sorts of things, Chair, and I was wondering whether Medway had an appetite to do something organically without being overly reliant, because I know your hands are tied somewhat, but, you know, do something, because I don't know of any dentist that works full-time for the NHS. They'll be part-time for NHS, part-time private. The way you access private is you buy it. You know, we might want to work with charities. We can do that as a local authority to buy UDAs in the private sector, which our population may well be able to use. What I'm trying to get at is I think we need to be thinking a bit outside of the box, because as I guess I'll label myself the chief corporate parent, I get to sign off all the requests for very young children who have to have dental procedures to remove their teeth. And it's distressing every time I have to do it, because I know that, you know, their quality of life as adults is not going to be good. So while I really liked what you presented, I think if we just keep thinking like that as a health and wellbeing board, it is very limiting, because it just grinds to a halt. So maybe some other ideas, Chair?
Just before you come back on that, I think that's absolutely right, Leanne. You know, you've sort of read my mind, because I think going into, the ability to go into a community with an offer and at least an initial examination, whilst it sounds a bit old-fashioned, I think badging that as an organic sort of grassroots, bottom-up way of getting people to re-engage with dentistry, in addition to the work that we do at loads of events and with schools through public health. You know, that is happening, and obviously the government, the past government actually, and this one, have picked this up through the school service about, you know, brushing your teeth and so on. It is critical. But to get into some of our communities, I think perhaps we need to put that as an exploratory action. Leanne, you're absolutely right. You know, is there something else in addition to what you are doing that we can collectively support to get those thoughts going for people? Habib, next, please.
Thank you, Chair. Just on the target, the dentist plan target for patients to see dentists. Talking to colleagues as well who I'm standing for today, Laurie, we believe that it is a bit unambitious, looking at the numbers and the target you set. But one will wonder, what is the capacity of the provision, you know, and how many patients you can serve, basically, you know, how many vacancies are there, and whether the incentive package only cover the 10 dentists, whether that's enough, and is there any issues from your perspective with regards to the fees that are being offered?
So I think firstly the targets are set nationally that we've got around this, and this is just measuring where we are nationally against that. I'm not saying that that's kind of right, then we should be accepting as only 32% of the adult population are seen as new patients, or where we are. So I think, again, that close back to that conversation about actually let's look at, I guess, what we need, and that's the bit that we're just looking at, I guess, data in isolation. What's the need of our population, and then how do we get more targeted in terms of the support that we offer? And that could be, as we mentioned, it might be that we partnership on some dental van that goes out into communities and does that outreach work. But there could be other things that we're doing, and I'm all open to exploring things outside of the box. I think the purpose of this kind of just setting it out now, this is where we are. I think that's what we're just saying. This is where we are. These are some things that we're doing, but that we're not limited by that. We do want to explore, I guess, other options as well. In terms of the UDA rates that you were referring to, in terms of how much that's been offered. So I think there are national discussions that are happening with the British Dental Association around the contract. So some of that might play out in terms of what then comes through further down the line. But I think our incentive, because again, we're not necessarily able to compete with the private market, it's what else we can offer. It's what else we can offer as a healthcare. And also it might be things like, if people may really want to come and do the outreach work, maybe that's something that we can offer that other people can't. So I think it's almost that opportunity we need to engage with the profession, understand exactly what they want, what do they want from working in the NHS, and how can we start to offer that.
Okay, thank you. Jane Perry, please.
Thank you, Chair. Working out the microphone. I suppose I'd be wrong of me not to address the education and training piece. And I suppose being fairly new to Kent and Medway and getting used to the area, I suppose what would be really helpful to understand is what is the ask. So in terms of pharmacy, there is a school of pharmacy here. Is the supply of pharmacists enough to provide the local workforce solutions that are required for that? And are there additional requirements that are needed because the role of the pharmacist has changed dramatically, hasn't it, over the last 10 years, and we're seeing them much more clinically orientated, which is fantastic. They're coming out now with prescribing qualifications, whereas they didn't used to do that. But there'll be a gap between those who have that new training and those who have the old training. So I think it'd be really good to understand what those local needs might be in terms of that. Also be really keen to know what the sustainable workforce looks like here as well. My observation from nursing and allied health is the huge reliance on international recruitment to service the local trusts, and we're trying to drive towards being able to recruit local people into courses that then live and work in the area and stay in a part of that community. I know with dentistry there's been quite a number of conversations about whether a dental school in Kent and Medway is something that we should be looking at, and I know colleagues in KMMS are actively having those conversations with yourselves about that. We've got quite a strong will to set up dental hygienist, and we're actively pursuing and looking into that at the moment. But I think from a sort of education and training point of view now, it's really, for us, I think, an employer-led initiative. What is the needs of your organisations, and how do we then adapt the training to support those needs? And just to say that we'd be very willing to work with you in that way to make it real and useful. Yeah.
That's good to hear. Jane, do you want to respond to that?
Yeah, sure. So I think there's a couple of things really. So when we've been speaking to pharmacy and dentistry colleagues around some of what they've got, I think one of the things that, and I've mentioned at the beginning, that there's a lot that we offer in general practice about ongoing. So there's ongoing education, training, and development that we offer. Lots of packages of support, PLTs. That those things don't exist in the pharmacy or dentistry world at the same level. So I think there's an element of parity in terms of what we offer. The other thing is, I think, and this is where the pharmaceutical teams particularly have asked for this, is how can they engage in maybe PLTs with GPs? So almost that partnership working that they really want. They want to be able to explore what it could look like to work much more closely with GP colleagues, because obviously they're taking more and more of this clinical services on, but actually that will only work if actually the pathways work really well with the GP practices, the relationships work really well. And I think going back to your the original point around the pharmacies and kind of the IT skills, actually I think the biggest thing that they achieved for Maritime Health was the partnership working. The technology enabled that, but actually the partnership working, the relationships and everything is really important. So I think it's almost like trying to be seen at kind of that same level in terms of what you're offered, that we can offer. In terms of the sustainable workforce, I think that would be good. So one of the things that we've put into the strategy is around workforce planning. So the challenge we have in Kent and Medway is quite often we tap into the workforce that we have available to us, but maybe the bit that we haven't done is looked at what the needs of our population are across Kent and Medway, and then be much more targeted actually to say, this is what we need. We know mental health is a big issue in this area, and actually it's mental health practitioners that we need more of. But when you come to community pharmacy or dentistry, again, it might be linking into say, actually, these are the needs of our population. We need more hygienists. We need more people going out to schools. We need that other kind of aspect of support. So I think that's the bit we were trying to build. So we need to do the workforce modelling first, and that would be really good. The offer to link up would be really helpful. And just to explore that conversation a bit further about how we can really try to join up those programmes.
Thank you, Jane, and so that's helpful, and we'll put that linkage as part of our actions, I think. David, please.
Yeah, thank you. So a number of things I'd like to raise. So you mentioned in the presentation a number of opportunities for collaborative working with public health. Would absolutely love to pick that up with you. There's quite a few bits there that we could do together, certainly around the communications work, etc. Very happy to work with you on that. Also around public health intelligence, we've got a great public health intelligence team. We can help you provide sort of more information about some of the detail that might help you. And then you mentioned the JSNA, work on the JSNA chapters. Would love to work with you on a JSNA chapter around oral health. We had one for a while ago, a bit out of date. Love to get one updated. So usually our problem is finding somebody to work with who can sort of help write the chapter. Our public health intelligence team can help with the intelligence side of things. So it'd be great to work on that. Also pharmaceutical needs assessments. So we went out to tender for a provider to produce our next pharmaceutical needs assessment. We're now in the process where we're going to be looking at the bids. We should be getting started hopefully in the next couple of months or so on it, and then we'll be working on it probably over the next 6 to 9 months. There is a fairly standard formal process that we need to follow, which will involve bringing it to the Health and Wellbeing Board at least 2 occasions, once in the beginning, once towards the end. And that will be a great opportunity to pick up on a number of the aspects that you've talked about, like some of the new services and other things. And linking back to your answer to Taff's question as well, we can bring all of that in together into the P&A. So it'd be really good to get as much input as possible from you and from other pharmacy colleagues into the P&A as we're developing it. And then finally, around access to dentistry, I don't know if you're aware, but we did a health and wellbeing survey in Medway about 2 or 3 years ago now. And this was a proper epidemiological survey, took a random sample of residences across Medway, and then went and interviewed, did a door-to-door interview across a range of different health and wellbeing measures. But that included whether or not people had a dentist. So we've got quite granular data about the distribution of where people do and do not have a dentist, so we can provide information to help you with that. In fact, it's on the website. I can give you the link. So just looking at the data here, in some areas we're up to sort of 94% of people responding saying that they have a dentist, and then the lowest areas it's down to 59%. So a real range. And so got some nice maps and things that can provide for you.
Okay, that's great. Jane Black, yes, you look like you were coming in. I was just going to ask you, but you first, yep.
Thank you. I suppose it's part of the conversation we were having earlier, but I think the collaborative working, not just out in the community, but also for the acute, there's opportunities that, particularly with pharmacy, that we could help and support with. So I think, be really interested in working with that. And I think also some of these proposals, certainly what would the impact be on secondary care, particularly for those people that have to come to the urgent treatment centres or ED, etc. So that will have a positive impact, certainly for my organisation.
Yes, Ash, please.
Thank you. It was just sort of a mixture of answers for various questions which have been asked. So, I think the first and foremost I would say is we talked about maritime health, and I can't agree more, is that it's all about relationships. Every time I've seen any project succeed, I've found that relationships were the key. And the good thing which we're trying to do in Medway is we've appointed 2 medical directors for primary care in Medway, which is very good, because what they can do to help us is build those relationships between the clinical directors and the PCNs and the pharmacies. That's number one. And second is we are also in the process of getting some pharmacy PCN clinical leads. So that means is the community pharmacists finding a PCN lead from them, which can become the link with the clinical director. So fostering those relationships will be very important. And the medical directors, which we have just recruited about a few months ago, who would be the key in making this happen for us on the ground. So that's the first part. You mentioned also about the IT. IT thankfully has moved on a little bit from when you might have seen. Now we have been able to link the practices with the pharmacies directly. Now this is through a mechanism which technical it's called GP Connect. So the pharmacies are able to see the records which we have got, which we enter into our GP practice, which makes them far more effective. The advantage of that will be for the number of small conditions which they can see, simpler conditions which they can see. That reduces the workload for us because we can shift that activity away from the practices to the pharmacies. But to achieve that, we need to do 3 important things. We need to foster those relationships which we were just talking about. Second is we need to get a buy-in from the practices themselves to be able to do that, and we need local comms. There are some good practices happening. Maritime Health is a very good example of that. But then there are hot spots in Medway, which we need to identify to say, these are the areas where this is not actually working. We need to actually work with the public health in that areas to say, what's not worked here? What do we learn from Maritime Health? and to try and bring those changes in that area. So we would really welcome support from you and the public health to make that happen on the ground. We can help you identify what those hotspots are, but when the change for the tactical change to bring the change on the ground happens, we will need your help to do that.
Thank you, Ash. And before anyone else comes in, look, I think that one of the important things, and I absolutely understand the emphasis on partnership working that you've made as far as the success that the Maritime practice have had. We've got 38 GP practices in Medway, still of quite a variety of shapes and sizes. And I think, I do want GPs to feel comfortable with the idea that pharmacies might be dealing with some of these smaller conditions. And, you I guess, will know better than us, and we stand to be advised by you on the best way to do that. Because, GPs are a trusted part of our community, notwithstanding the way that people, have a lot to say about the difficulties and sometimes perceived difficulties of getting an appointment. That lovely human face is really important. And if the human face that somebody sees is the pharmacist, I want to feel confident that the GP whose patient has gone along to see the pharmacist is happy about that. Now, I don't know how we, in sort of formal terms and strategic terms, how we sort of represent that, but it's important. Because there is a propensity of people to say to their GP, oh, well, my pharmacist said I can have an antibiotic, for example. That is a very popular way of dealing with that sort of relationship, whether it's true or not, actually. And, I've seen there is evidence that it might be a little bit easier to get an antibiotic by someone who's demanding it for their sore throat than it would be for a GP who would take a more nuanced, longer view, perhaps because of time pressures. So we've got to get these, if partnership working works and has been very effective and people are happy with it in the Maritime practice, we need to learn from that and get those relationships right. And I know that sounds a bit sort of motherhood and apple pie, but it's important. Because I don't want to alienate any part of the system that we're trying to improve capacity for Medway in our situation where some GPs have got 4,000 people on their books compared to 2,000 in other parts of the country. That's the reality of being a GP here.
And that's why it's more important to use the pharmacies more effectively, because what that does is I can then shift a level of activity away to the pharmacies, and then I can focus on those more complex, nuanced patients where my expertise is needed. But you're absolutely right, Councillor Murray, is we need to build that relationship. We need to help to build that relationship between our GP colleagues and our pharmacy colleagues. And it exists, but we need to foster it more. Because this is what we're saying is you're shifting a clinical activity away from you to another colleague. And when we look at our patients, we look at them as a sort of an extended family. So we want to be very confident that if I'm shifting my activity away to somebody else, I'm confident in the capabilities of the other person. And that is usually after we have developed good relationships. So we might have to actually work harder on that part of the story, that part of the narrative, to make it actually happen on the ground. But it's in the interest of the patients, it's interest on the GPs to actually do that.
I'll come to you, Jack. That obviously, Ash, I'm pleased to hear that sort of mutual interest is right. There is something quite glaring, isn't there, from the statistics you've put forward. If a pharmacy consultancy is £14, that's a lot less than a GP consultancy would expect. The pharmacy is not carrying the same overheads. So one of absolutely the worst things would be is for it to be perceived as a cheap way of people getting healthcare. How desirable that might be is another matter. But for engendering a trustful, confident relationship, both in terms of the treatment that people are going to get and the way it's perceived by the practitioners delivering it. I think that's important. Jack?
Yeah, and I think, I agree actually. And I think it's tricky this, isn't it? Because this is quite a big seismic change in how we want to deliver healthcare. And, you know, at the moment, pharmacists have a list of 7 conditions they can see. There are really funny specific things around it. So I'm just looking at them here, because I can't remember. Sinusitis, if you're over 12. Sore throat, age 5 and over. Earache, 1 to 17. So do you see what I mean? It's kind of, so getting the right people to the right place is quite tricky. And, you know, I'm a GP trainer. I spend quite a lot of time training GPs, training my staff, and how to consult. And I think that's quite challenging, I think, for a clinical pharmacist to do that. And I'm not sure the environment is the same. I don't think they have to go into a room. I think it's over the counter. So, you know, I get the intention of this. Is it going to work? Is it actually going to reduce, like, demand, or does it create demand? You know, it's one of those, it's really hard to know. I think it's really hard to know. Like, and I'm not against, like, collaborative working between pharmacists and GPs, but I just think we need to recognise that. This is not easy. And, you know, pharmacists will get stuff wrong, we get stuff wrong. When they get stuff wrong and bad things happen, what's going to happen then? And so I just think there's a bit of a way to go with this journey. It's good. Collaboration and working together is good. You know, they do have, so I'm just a little bit cautious around it, that sort of thing.
I think that caution is completely valid. And so what we need, I think, to do together is to build in some safeguards, don't we? And look, until you read that out, I didn't know that those 7 conditions had age restrictions on them. So now, if I go along with an earache to the pharmacist and I'm not 17 or whatever it was that Jack said, they'll say, no, I can't see, you've got to go to the doctors. So the promotion of what's on offer is difficult, isn't it? Because actually, it's only for, you know, those services are not available to everybody who might want to go along for them. So I think, you know, there's some work to do again with lobbying Wes Streeting and his friends. And, you know, look, hand on heart, I say that as a Labour politician, that they're not going to get everything right. And actually last night, I think it is worth saying, Jack and I met each other for the first time, and we had a conversation about, well, look, we've got to stop having this broken narrative and come up with something that is more positive and shows the kind of intent that we're expressing here. That is more difficult to do in the context I've just described, when part of the we're not broken anymore, we're moving on message is sort of fractured by, well, yes, you can go to the pharmacy if you've got an earache, but only in certain circumstances. So, you know, that's sort of 2 out of 10 for whoever came up with that, isn't it, really? And I think we have to be honest with each other. Eddie?
Thank you. Yeah, I've been wondering what I'm going to say, but to link on what you said, sorry, before I start, a lot of us moan about the service we get from Thorndike Health Centre because you just cannot get appointments. It's absolutely appalling. So I want to start with a positive. I actually do have an NH dentist, Premier Dental Care, Chatham, fantastic service. I'm not all moaning all the time. Recently, when I had a case of wanting to see a GP, it came back, no availability, contact your pharmacist and get an appointment there. Now, since it stopped being Boots and it's Bod Pharma, again, the service is really good. When I rang up, however, and spoke to member staff, the very notion of me talking to a pharmacist instead seemed to be something that she did not comprehend. I came off the phone thinking, I've just allowed myself to be fobbed off. So the idea that I could get to see or talk to a pharmacist instead didn't seem to be functioning. So when looking at your ambitions on page 31, I mean, they are really, really good. I mean, if this happens, it'd be fantastic. I do have a question is, what is the format, stroke, how much are or have been the pharmacists? After all, these are private companies, quite often chains, but sometimes they're just individual ones. I mean, what is the representation from them? How much are they bought in on this idea? Because obviously if they're not, it's not going to happen. And secondly, when it comes to availability, what the resource is going to be. And my third question is, sorry if I've missed it, but are we going to have a strategy on GP practices as well? It's not just on a personal level, but for instance, as a support worker, somebody's moved from Gillingham to Luton. I rang up the local GP services and they said no availability. So this person who isn't somebody that he needs somebody with him. He's got learning needs, he's got mental health. He can't just go back to Gillingham. This is a challenge in itself. So he really needs somebody just around the corner, but no spaces left. So what do we do about that? Thank you.
I think if we take that question last, that's not directly related to what we're discussing here, but it's an important question, and I understand, you know, where you're coming from on it. But if you can come back on the others, please, and then we'll sort of come to close the item and see how we deal with that, Eddie. Okay.
Yeah, sure. So in terms of how pharmacies are signed up or kind of on board with this, so I think in one of the slides we just put down, I guess, how many, because pharmacists wouldn't sign up to this if they didn't think they could deliver it. So for Medway, for Pharmacy First, 49 of 51 have signed up to deliver it. So I think that shows they're on board in terms of being able to deliver this. But obviously the gaps we do have is the contraception service, for example, is 34 out of 51. So I guess, but that might be again linked to clinical competency of staff, so they have thoughts about it. So pharmacists, before they sign up to any of these services, they will consider, do I have the availability of the clinical rooms, capacity, do I have the workforce, do I have the skilled workforce to be able to deliver those services? So for Pharmacy First, yeah, 49 out of 51 pharmacies in Medway are signed up to deliver that service. I was just going to quickly answer the general practice bit, because I think we've got, so when I mentioned at the beginning, there is a primary care strategy, and primary care strategy, obviously we're here today to talk about pharmacy and dentistry, but it does cover general practice and optometry as well. So we do have that. That's all in that one strategy as well, because we recognise, I'm only talking about these and the challenges that we've got here, but we do recognise there are other challenges that we need to work through as well. So general practice is included in that as well, when we're looking at that.
Yes, I mean, that is available, Eddie. It's there already, but we can think about whether we bring that back, actually, and through public health, actually, with the annual report this year, we've got some plans about access to primary care, so that will be coming through scrutiny as well. We haven't, you know, considered the fact that, you know, we've had a task group and that's the end of it, and neither has Suk and his team. Okay.
In response, thank you for your answer, but my concern is the staff that work at pharmacies, are they aware of that they are meant to be providing this secondary service? How well trained are they? How well informed are they? Even though the basic notion, please.
Well, that's part, yeah. So when a pharmacy signs up, they should be doing that work with their staff. So the staff should be aware that they're providing that service to the patients. So thing is, when these are new services, so I guess there's other things around new services coming in, there is a period, I guess, of embedding them in. So there are things that they have to work out. What's their protocols? What's the pathway between the GP to the pharmacy as well? So at the beginning, there were teething issues. We had issues with the IT systems. They didn't work together seamlessly. So that did cause a slight problem. But those have settled down and they are working effectively now. But if there are, I mean, yeah, if there are examples like that, I can take them offline if you've got particular examples where there are potential issues where there's some pharmacies that maybe aren't necessarily clear on the services that they're providing.
And there's a high level of sign-up, as we've heard from Medway. So I think that was a really helpful discussion. Thank you very much for your answers and to everybody for their contributions, ideas. We're simply being asked to contribute to the discussions, but I think we've got some clear actions. One of those is Jane linking with the university, linking with you about the training needs. That's important. David has made a very firm offer of the needs analysis using public health intelligence. So we'll certainly work with that, because I think that, you know, needs analysis is critical to service delivery, and it gets pushed aside quite often. But you know, that data is there all the time, and as David said, with a really dynamic and very professional public health intelligence team, that's support that we can offer. Some of the things that have been said about the way we engage with the public, particularly on dentistry, we need perhaps to look at that together, and similarly with Pharmacy First, you know, that these things are there. how are we going to work together to give people the right message that isn't either a sort of punitive message that, you know, you can only go along in certain circumstances, but that says this is an expansion of service delivery intended to make things more accessible. And I think we perhaps need, outside of the meeting, maybe to think about that. And I think that's something Health Watch, you can help us with, you know, in terms of spreading the word, but doing so effectively. And indeed the voluntary sector, our voluntary sector partners, I think have got some work to do there. So we've got a whole series of things, Jane, there that just to remind you, for agreeing this item, that we can wrap into, having only been asked to discuss it. Okay, so if you want to go ahead with that.
Okay, so the board are asked to contribute to the discussions, which I think has been full today, but to note the proposals and some of the challenges that have been highlighted, but in particular the recommendations that the chair has highlighted. I think you got them all from my list.
I think the one that I did miss there actually was what Leanne said about investigating a partnership with charities to see if we can get dentistry into communities, which I think would be very worthwhile. And in general, you know, sharing this message. You know, I want to hear pharmacies who someone, you know, might come along with a sore throat going, do you know what, get your teeth done. And I think that, you know, these have to be honest conversations, don't they? But it's no good saying that to somebody if their ability to actually find a dentist is reduced because of their low income or just general access. So we've got some work to do. But overall, thank you very much, everybody, for that item. So we've got half an hour to go. I just need to get people to agree, it says Steph. So is that agreed? Thank you. It's good that she's here, because otherwise, you know, I miss out on the formal bit. Is that agreed by everybody in the way that we've said it? Thank you. Thank you, Mark. You looked a bit bewildered then, but you're all right. You're on board, are you? Yeah.
Yes, I'm hanging on your every word, Chair.
Thank you very much, Mark. That gives me enormous confidence. Okay, so we're going to move on to the next item. That is an update on women's health, please. David?
Okay, thank you. Yes, so this is an update on the women's health work. We had a Health and Wellbeing Board meeting on the 27th of June that was focused exclusively on women's health. And I think that meeting worked very, very well. It allowed us to look at a number of different issues from different perspectives and was a really productive discussion. Out of that meeting, there were a number of actions that came about, and work has been underway since then to deliver on some of those actions. Some of them are still ongoing and will take a little bit longer to complete, but a number of them have now been completed, and these are listed in the paper. I believe there was a visit on Monday.
There was, yeah.
To women's health. To Clover Street. And I believe you wanted to give an update on that.
Happy
to just finish there.
Report on that. Thank you, David. And as people can see, some of those actions will be ongoing, but some of them we were able to conclude really quickly. And absolutely, I think everybody that was at the women's health themed meeting found it useful, and we invited a range of organisations who contribute to women's health. So we had, for this board's information, because quite a lot of new people here today, we had people who help us with domestic violence. We had people from other women's advisory organisations, and as a collective, it was really helpful to talk about the services. Now, on the Women's Hub itself, an initiative with non-recurrent funding, so I'm not very happy about that. The Medway bid has gone in, so a collaborative bid has gone in. For those at the meeting, and you can see from the minutes, the Kent hubs were getting into place. The Medway initial approach had been rejected. It's been strengthened collaboratively, and it's gone back in. So I'm hoping, and we need to be alive to getting that information. that it actually will happen. It won't be a single location. And we can have our views on that, and I don't think it's necessarily helpful, nor is it helpful to have non-recurrent funding. So, but I think the more successful the hub can be, and the more we can demonstrate that by having it at all, the women's services improve in terms of take-up, and obviously we'll be, as usual with public health, doing some analysis on that, I'm sure, David. But at the moment, we need to know if the proposal has been accepted. That was spoken about at Clover Street. Stephanie and I went along to the meeting. We didn't have any representation from the ICB. Malti was unable to join us. And that was a pity, because what became very clear for sexual health and menopause services is that, for a start, for the longer-acting contraception, LARC, there are, in fact, in operation 4 different tariffs. Now, that makes it very difficult for GP practices who deliver most of those services to make a judgment about whether it is worth, in monetary terms, that, you know, I'm sure there's no lack of intent or lack of will or any sort of idea that it's not worth doing in, you know, as and of itself. But if there are 4 different tariffs and, you know, 3 of them are lower than the highest tariff, then training practitioners who can fit hormone coils and deliver the longer, much longer appointments, half-an-hour appointment needed to make sure that that happens properly, will put GPs in a situation where that decision is a difficult one to make. And consequently, we've got fewer people able to offer that service and waiting lists of about 4 or 5 months. Now, the Clover Street Clinic are not contracted to offer that service as a standalone service, although they sometimes offer it as part of a wider sexual health service that someone has come along, because we are covered as women for sexual health and contraception until we're 55. So they are able to actually deliver that service to some people who come with a different associated problem. But that makes it in the lab. You know, you might be lucky enough to be lucky enough, might be, you know, not a great way to describe it. If you're in that situation and you're able to get that service from Clover Street up and until you're 55, all well and good. What happens more often is that people will go for a Clover Street service and be told, I'm sorry, I've got to send you back to your GP in order to access the LARC service, and then there are 4 to 5 month waits in Medway. So, will having the Women's Hub make that any better, was the question that I asked. And collectively, the people at the meeting weren't able to answer that question. So, I guess dependent on whether the hub is approved at all, and then further into its operation, we'll find out whether that is actually correct. And you know, a different perspective was offered to us than the perspective the board heard. The board heard very clearly, and we heard through our menopause big conference day that we had with the specialist consultant from Medway in attendance, we heard from women that have to fight for menopause services when they go to their GP. And that was a very clear message from about 200 women assembled on that day, and continues to be a message. The representative that we had at the meeting from the LMC, which was not Jack, it was someone else, said they felt that the kind of media push on menopause had turned negotiating services through a GP appointment into an argument that didn't necessarily have to take place, that patients came along with a predefined idea of what ought to be available and were sort of antagonistic about it, whereas until Davina McCall, you know, got involved, nobody did that. Now, I'm afraid at the meeting I didn't accept that. I think, there is a weight of evidence to suggest that women don't get taken seriously lots of times, and that if they want a blood test to see whether they're actually in the menopausal phase or even in the perimenopausal phase, it's actually quite difficult to get because not all GPs have got the training, and it's difficult. Jack's going to come in there. So the same sort of two sides of the argument that we heard at the Health and Wellbeing Board have now sort of come into a professional arena, but there is an issue, and we've got to pass this on to the ICB, and you're the people here to do it through today, with those tariffs. You know, having 4 different tariffs to deliver the same treatment isn't helpful and sets, you know, different parts of the services against each other. So I'm going to bring in Jack, and then perhaps Suk and Ashtu might have something to say about it. Yeah.
So I just wanted to talk to the menopause issues, and you know, I don't think any GP would say that it is wrong to treat the menopause. I agree. There's clearly lots of evidence to suggest it improves people's lives, they can function more. And I would be interested to know, because you said that obviously there were lots of women saying it was really difficult to access, but I wonder how many prescriptions are issued in Medway for HRT, because that would be a good way of balancing it, because actually my suspicion is there are probably a lot. And what I would say to that is that, you know, my own experience reflects this as well, that I prescribe a lot more HRT than I did 5-10 years ago. The evidence has changed, and it's a good thing. It's extra work without any resource. No extra funding has gone into general practice to support menopause whatsoever. So there is, you know, that's one of the issues. It's more difficult to get through to a GP. I mean, that's just the reality. I'm not saying it's wrong, but it's a reality. And the other thing is that HRT does have complications. It can be quite complicated. You do have to monitor it. And there is a guidance. There's a formulary that the ICB have produced, and there is no indication for a blood test for HRT. That's just a medical thing. But I know that was just a little thing. And the fitting of the Mirena coils, or the IUS coils, the hormone coils, which are often used in conjunction with HRT and also used for contraception, has been an issue for a long time. The tariff actually is paid for by public health, not that lot. And both tariffs, they are different, but they don't really resource the amount of training that is required, and the maintenance of that training, and the assessment of women, and the discussion, because it's just not a simple thing. There's a lot to discuss. That really does take time if it's done properly and well, and I think that's what we want. We want this done in a safe, good way, and that really does take quite a long time, and so it should. And without the adequate resource to do that, I think a lot of us worry that GPs are going to stop doing it, because we're getting to a point where we have to choose what we do. So we've been subsidising coils for years. That's just something GPs have done. Rightly or wrongly, they have. But it's getting to a point where I think GPs are going to have to say, well, I actually need those appointments to see all the other stuff. I can't use that period of time, that GP's period of time, or even that nurse's period of time, to do that, because it just isn't resourced adequately. So the resource is really important. And I know GPs always talk about money, but we see it, we feel it, you know. And we've demonstrated it. We've got models that are sort of based on published evidence for the amount of time it takes and what it costs to fund everyone. We know all that stuff. And it just isn't kind of meeting the need.
May we ask, Jack, what your view is on the development of the women's health hubs in having a positive impact on the things that you've just said are becoming very difficult?
So I think from LMC point of view, I think I would probably rather we resource practices that are already there as physical things that have been around for a long time, and are places where people go that can coordinate care, because actually when you're coordinating HRT and someone's on blood pressure tablets and they're diabetic, I'm telling you, it gets really tricky. And someone has to coordinate that care, and that has to be a GP, really. So I'm a little bit wary I'm wary of chopping up bits of care into different segments, because unless it's very limited and straightforward and self-limiting, that's fine. As soon as you do it for anything else, you create a lot of noise in the system. And actually that just creates a lot of work. And I think some of that, it just needs some oversight, and it's quite difficult. That's kind of the work that I do. Yeah.
Yeah, I mean, my wariness, and I'll come to Ash and Sook, is this non-recurrent funding. That if we go down a track where we change things, and it works or it doesn't, I mean, I suppose if it doesn't work, that's the idea of there being non-recurrent funding, so you can just go, well, it hasn't worked, so we'll go, but whatever, there's going to be destabilisation of what exists, however good or not so good it is, and however patchy it is. So I think that this is a real critical juncture in the way that we think about what's on offer for women at this time. So Ash, you wanted to come back.
Thank you. Thank you, Councillor Murray. Just building on the questions you've been asking and the answer which Jack gave. The first thing Jack asked is, are we issuing more HRT than we were issuing 5-10 years ago? The answer is absolutely yes. The second question then is, have we been able to reach out to every woman who needs help in this area? And our answer is unequivocally no. We're still failing a lot of women in Kent and Medway. We need to do more than what we currently are doing. There's no questions about it. And then the question comes, you asked us, is how do we support them? How do we make it more effective? The problem, what's happened is, Councillor Murray, is over the years, the levels or the skill sets of a lot of my colleagues, I would put myself in that, have not been as good as it would have been if I was constantly doing women's health. Now, we need to try and bring those skill sets back again. Now, you asked me as a question is, this is a non-recurrent funding because the NHS England has given us one-off funding. Now, the whole idea behind this funding is to be able to start building those skill sets again. Now, what we are saying is not about building a building around which you will say this is a hub. It's about building those skills or training those colleagues again to say, yes, you will be able to provide this service. We need you to also be able to train the practice colleagues next door and the ones after that, so that you build a momentum behind this. So that will be a very critical part as we go forward. The third question you asked us was about the coils and the tariffs thereof. There are actually, if you look at just Medway, then we're looking at two sets of tariffs. One is for the contraception larks, which is, as Jack was saying, it comes from the Medway, and the second is for the non-contraceptive lark, and there are two slightly different tariffs. The problem, nub of the problem in a way is sitting there. Now, the one nub of the problem is sitting there is because to be able to run services like this, we need to have sufficient flow through our practices to be able to, one, keep the skills of the people up, to be able to finance, even if we have to make it financially viable, to have the number of people and the rate at which we are getting paid. Currently, that's a discussion we need to have in terms of, if we're going to do this, how are we going to do this? Make sure that if we identify a PCN or a neighborhood to say, these are one or two practices in the neighborhood which can actually run as for the whole of the neighborhood, so that they have the number of people going through that to be able to do that. Number two is, which is critical, is also the finances which sit behind that. That's how you can actually get on top of this problem. Number one is skilling more people up to do the HRTs and other things. And second is bringing the PC. You can't do a service like this at a practice level because we just do not have the footfall in a practice to be able to deliver this service sustainably. This is where we need a PCN or a neighborhood to do it. And that, as a part of the Women's Health Hub, that's what we've been talking about. So that's why we're saying that this investment which we are making would actually help us to drive that and make that happen. And if we are able to get the right amount of people through that PCN or a neighborhood system, then actually it will become a self-sustaining system, and we won't need any more investment into that.
I do understand that, and I think that was explained actually at 5,000 miles a minute by the representative that we had at the Women's Health Hub meeting, and you've slowed it down and made it easier to interpret. And I suppose fundamentally, yes, if we've got a sort of neighbourhood block who can deliver the services, and we're not relying on a particular, on every GP being able to do it, especially if their patient cohort don't need those services, then yes, I understand where you're coming from. The problem we've got in Medway is, first of all, we don't know whether actually we've got an approved women's hub, and we're already, in a year of non-recurrent funding, a long way behind the curve, because everyone else has already started, and we haven't yet got approval. So I suppose something back to the ICB will be, should the health hub in Medway be approved, are we going to get the extra months of funding, at least for this first non-recurrent year, to give us the same opportunity as Kent have had to make a decision about whether the thing is working. And a point, David, in your list there, and it was back to a point that Leanne raised, this is a very medicalised model. And I think we have to consider, if we're looking at women's health in the round, that there are alternatives. And I don't mean, sort of herbal alternative, but a different way of supporting people through difficult times that doesn't necessarily involve HRT, especially given that there are people who cannot access HRT for medical reasons. And I think that, we do need to consider that, not just in a sort of, warm and fluffy way, but take that on seriously. Because I think one of the rise in HRT has been because it's been the only show in town. And it might be the only show in town, for all I know. But I think the point that Leanne made was well made at the Women's Health meeting, that there has to be some room within the women's health hubs to offer a different model, not just because some people can't access the sort of whole medical regime, but also because it does give people a comfortable alternative and a bit of time to think. As much as people might come in demanding HRT and feel like they're not being listened to, that might be one aspect. There are other people who may, feel like they're being railroaded into it. So, and we should be attending to all sides of that case, I think. So an answer from you on whether we get, some help on whether Medway will get the Women's Health Hub at all is prescient and helpful. And then our ability to have a fair crack of the whip, given that we're late to the initiative and the refunding is non-recurrent, would be helpful, please. Eddie, and then Habib.
Okay, I'll try to be quick. Can I say that I'm pleased to hear this conversation going on? I do think this is an ongoing, living, breathing thing that needs to be highlighted. At the last meeting, I came away from that meeting having found it very interesting, the discussion about women's strategy, health strategy, but also very disheartened. And I gave the example of over 30 years ago when I had to go to a female boss and represent, as a trade union rep, my female colleagues about, so I can't think of the right terminology, so tell me off, but perceived women's issues, period pains and all those type of things. I did get the impression that maybe the very fact that we're speaking about it in these terms, it's as if we're only actually now officially recognising how important these issues are. But then one of your answers you gave to the council, Murray gave me the idea that, no, we've been looking at this for a long time, but it's just taken a very long time to get somewhere. All the more reason for us to keeping our eyes on it. One thing I would urge is that men are involved in this. So some months ago at work, this is Sanctuary, supported living, I attended a training, and I'm trying to think of the right language. It was something like women's health issues. It was on Teams. From what I could see, I was literally the only man attending this training. I wanted to be there because, I support women as well as men. I wanted to have a better understanding of what the issues were. It's not, it's not just men, because that was a female boss I had that problem with. So bad that I had a female colleague in tears, You may assume that she could go to a female boss and better talk it through, not necessarily, but obviously there's, as we said, a lot of ignorance and just don't give a damn from men, so they need to be fully brought in on this and try just to have an understanding and some conception. That's it, really.
Thank you, Eddie. It's an important point to make, and, I think one that has got its feet in the fact that very often if a woman comes to see a GP and the GP is a man, it might feel, even though it necessarily won't be, harder to have that conversation. So I think that's an important point. Habib.
Thank you, Chair. I mean, this conversation is very welcome. My question is, what is the difference between the current proposal compared to the previous version? When was it submitted, and when is a decision expected? Also, under 4.3, we talk about the NHS England objectives. So where are we in achieving the 10 key objectives against the plan?
Well, I think the first answer is, Habib, we only heard on Monday that the bid had just been submitted. So the answer to that is very recently, and you've heard me ask the ICB to give us an answer, and when that answer is given, we'll share that in a briefing note because it is important. For the rest of it, David, I don't know if you would like to answer, and then I'll come back to Ash and Suk, and then I'm going to close this item because we're supposed to finish at 4 o'clock, so I am mindful of that. Thank you.
Yes, so the 10 NHS objectives, as the note says, they are addressed across the joint local health and wellbeing strategy and the integrated care strategy. Both of those strategies are set to run for a 5-year period, so it'll be happening through that period.
And we're keeping the joint health and wellbeing strategy live, Habib, so we'll be providing updates and, where necessary, reprioritising and changing if we see that we're not getting where we need to be. Anything else, Suk and Ash, before I go to Tas wants to come in as well. Yeah.
So I don't know the dates or anything, but we'll find that and then we'll provide that to you.
Thank you very much. That's helpful. Tas.
Thank you, Chair. I just wanted to draw attention to point 335 here. It says inclusive further engagement with women who are underrepresented. We have done that engagement. We are currently putting together a report. So if anybody would be interested to see that, I'm happy to pass that around. Yeah, of course. I'll send it to Stephanie. Thank you.
Great to send that to Stephanie, please, and we'll share it with the board. Thank you for letting us know. Okay, Jane, over to you on that one.
Thank you, Chair. So the board is asked to note the update provided in the report. I think we've picked up the, just to know around the funding, around the health hub, so that'd be great, but also just to consider alternatives to the delivery models.
Thank you very much. Is that agreed, everyone? Okay, last item, the work programme.
I'll be very brief. You probably noticed that the next meeting on the 21st of November, one of the items on there is on the local plan. A report has been to all the ONS committees on the local plan, tailored to the specific remits of those committees. So what I'm asking board members to do is to please think about what they would like to be presented to the board, and send me any ideas as to what you would like covered, so that we're not rehashing the things that the way that the report has been presented to scrutiny, because obviously we're not scrutiny. So if you can please send me your ideas, I'll be very grateful.
Yeah, and thank you. Just on that, I would like to think that colleagues in the ICB have contributed to our local plan consultation. If you haven't already, there's still a bit of time, because, it is about Medway in its entirety and all the infrastructure and services, not just about housing. So it's really important to be able to say that from this board. And as Stephanie has said, ideas coming in when we hear about the local plan at the board in November would be very helpful, because it is about the future of Medway in its entirety and the way we deliver that to our community, not just about whether or not people want new housing estate down the road from them, although that is important too. Okay, thank you. Any other comments on the work programme? Yes, Mark.
I just wondered if we needed to insert anything in view of our discussion on the first substantive item this afternoon on children and care placements, anything to do with a task group or anything like that. And do we need a further report perhaps at some stage on the dentistry and local pharmacies, because it struck me while I was sitting listening to the debate that it was an ongoing item. It's very much a work in progress. Having said that, I've no idea when the best timing to have a report back would be. Thank you.
No, I wasn't thinking of a task group for the Health and Wellbeing Board, Mark. I was just wondering that if we need to get together with officers and have a sort of task and finish to try to get to a position where we can communicate with other authorities and get that going. So from the Health and Wellbeing Board, there will be a letter to the other authorities about who is placed here and what our expectations are. There's other political work going on about a protocol. And for officers, I think some of the things that have come forward today, we'll get James and we'll report on that at the next Health and Wellbeing Board. On the general issue of coming back on dentistry and so on, we should be doing that through the strategy, shouldn't we, David? But if you want to just...
Yeah, absolutely right. So we could do that through the Joint Local Health and Wellbeing Strategy, and the pharmaceutical aspects can be handled through the P&A, the Pharmaceutical Needs Assessment, which will be happening over, as I said, over about probably the next 9 months. We'll come to the Health and Wellbeing Board at least twice through that journey.
And that'll come to scrutiny as well, Mark. Are you okay with that?
Yeah, thank you for those answers.
Yeah. Okay. So I think with that, the work programme is agreed. Can I take that? Okay, so thank you very much, everybody, for coming today, and we'll see you in November.